Okay, thank you very much for the introduction. Thank you very much for the invitation. So, yes, I will talk about modeling of metastasis today, which is and at the organism scale. So not at the cellular scale or cell migration scale, as Christelle was showing just now, or not even like at the tumor scale, but really at the level where there are several tumors. And just a quick introduction to myself and to a new team that has been newly created last year, which is called COMPO, which stands for Computational Pharmacology and Clinical Oncology. And well, we are doubly affiliated Inria Interim team, where we have like really three poles in the team with clinical oncologists, pharmacologists, both on the experimental and clinical side, and mathematical modelers. And the strategy that we develop is to try to integrate all the types of data that can be collected or that exist in clinical or even experimental oncology, and try to use this data to inform mechanistic models and to derive methods that can be in turn used for either on the basic science side to generate biological hypotheses and test biological hypotheses, but most of the activity is concentrated on the clinical applications, with trying to inform and to better design clinical trials, and of course for personalized medicine and personalized oncology. So, and I use my time here to make a small advertisement. We are currently working on a very large and very exciting project, which is where the mathematical modeling part is called the Quantic project, which stands for Quantitative Modeling Combined to Statistical Learning to Understand and Predict Resistance to Immune Checkpoint Inhibition in NSCLC, non-small cell lung cancer. So we are modeling a large data set that is collected during the Pioneer project, which is a national level RHU, where there are really well, in total there are 27,000 variables per patient for 450 patients that are followed during their treatment with ICIs, immunotherapies. And then the very unique part of this project is that not only there are baseline data from biopsy, but there is a second biopsy that is performed giving access to tissue data, not on treatment tissue data. And also there is quite a bunch of longitudinal data that is collected at multiple time points, especially from immune profiling with a lot of variables. So, well, this leads to a really challenging project where we are trying to integrate this data and develop mechanistic models for this. And the reason I'm mentioning this is that we have currently an open position, an open postdoc position to work on this project. So please, if you're a PhD student or somebody looking for a postdoc, don't hesitate to contact me if you're interested in working on this project. Okay, so now I'll move to the main topic of my talk today, which is metastasis. So as you probably all know, metastasis is the process of secondary tumors colonizing a distant organ, and it's a very important problem, of course, in cancer, because it is the main cause of death. Of actually 90% of deaths from solid cancers are due to metastasis, and it remains poorly understood. And there are several exciting somehow biological findings that are amenable to a dynamical mathematical description that could be interesting, such as the self-seeding process, where we have a exchange of cells between the primary tumor and the metastasis, the phenomenon of the pre-metastatic niche, and a phenomenon where that interests me quite a bit, and I'll try to show you some data and modeling on that, which is a distant inhibition of angiogenesis by endogenous molecules. So these are for the biological side, but of course, well, in terms of clinical challenges, there is a lot of questions associated with metastasis where mathematical modeling could help. And one of the big questions is to be able to infer the burden of occult micrometastasis from only data that we have, because of course we are not able to detect small tumors. And another challenge is to try to personalize, well, it's actually quite related, but to personalize adjuvant therapy for early stage cancer, so for instance, breast cancer. And another question again is to try to disentangle or to quantify the differential effect of therapies on one hand, the primary tumor, and the mets on the other side. So what is the background on modeling metastasis from a mathematical and statistical point of view? So there are not so many models in the literature. I mean, at least compared to all the efforts that have been pursued for tumor growth modeling. We can find some early statistical models for the probability of metastatic relapse in the literature, and as far as like biologically based or so-called mechanistic models, there is a very interesting paper by Liotta, Seidel, and Kleinerman in the 70s that was confronted to experimental data. And later on, there have appeared some semi-mechanistic models for the description of the metastatic development at the organism scale. And especially there's one important paper by these Japanese folks, Iwata, Kawasaki, and Shigesada, that will be like the main basis of the framework for my work today. And there are also works based on stochastic models for stochastic dissemination or stochastic events on mutation at the cell level, especially by Francisca Michor and her group. So the outline of my talk will be to briefly show you a simple mathematical framework for modeling metastasis, and then try to apply this framework to try to gain some biological understanding about 4 questions where we will compare to experimental data, and then try also to show you to apply the model for clinical applications in the context of brain metastasis from lung cancer, or prediction of metastatic relapse in early stage breast cancer. So basically, the model of metastasis that we use is a gross simplification of the process of metastasis between 2 things, between basically growth and dissemination. And there is growth of the primary tumor, denoted GP here. There is growth of the metastases themselves, assumed to be here uniform, I mean, homogeneous and the same for, I mean, governed by the same growth law for all metastases, and the dissemination denoted D. And from this, we have like the typical schematic of the clinical history of a patient, where there is a start of the primary tumor, the primary tumor grows, it might become quite large before it is clinically diagnosed, and then when well, for typically breast cancers, then at the time of the detection of the primary tumor, there are no metastases that are visible. The primary tumor is removed, and then following some time like the metastases can grow themselves and lead to relapse when they reach a given threshold. Okay, so this framework is translated, this model is translated into mathematical equation using an ODE for the growth of the primary tumor. So typically the Gompertz law, the dissemination rate is assumed to be proportional to the volume of the tumor, not to the volume of the tumor to a given power. So then we have like two parameters. This parameter mu, which quantifies somehow the metastatic aggressiveness per cell that is probable to disseminate, and the cells that are candidates to leave a tumor and to lead to metastasis are cells that are described by this quantification here. And for instance, if you take this gamma equal to 2/3, you have like something that is homogeneous to the surface of the tumor, and so you would consider that only the cells at the surface can live. If you have gamma equal 1, basically all cells have equal probability to leave the tumor, and if you have gamma equal to 0, then you have only a constant pool of cells, for instance, cancer stem cells, that would be able to live and lead to metastasis. So then translating this, so there is this nice framework proposed by Iwata and et al., where they proposed to look at the size distribution of the metastasis structured by the volume of the tumors. And when you write the growth of the metastasis in size, then it translates into an advection term in the PD here. And the dissemination is represented by a boundary condition on the influx, on the inward flow of new metastasis at minimal size V0, which is the size typically of one cell. And you can also consider secondary dissemination, that is dissemination by the metastases themselves. And I put parentheses here because it makes the calculations and like longer and sometimes we have often observed that it is negligible in front of dissemination by the primary. So then from this equation, from this row, you can compute some microscopic quantities such as the total metastatic mass. And when under the assumption where you neglect the secondary dissemination, then it's just a convolution formula, and you can also derive the number of metastases with size larger than some given visible threshold, which is exactly like the observable, the thing that you can observe from experiments or from clinical data. And from this, you can define formally the time to relapse, which is the first time at which the number of visible metastases reaches 1. So now, in order to confront and to compare these models to data, we need to have a procedure, a statistical procedure for model calibration and for estimation of the parameters. So the classical approach is, so typically the type of data that we have is that we have a population, either a population of animals or a population of patients, sorry. And the classical approach would be to fit individually each subject separately with, for instance, using the maximum likelihood estimator, which basically reduces to the least squares problem. And then there is this very nice framework of using the so-called population approach, where you consider all your subjects pooled together, and you do so by introducing and assuming a statistical distribution of the parameters within the population. So for instance, a log normal distribution of the parameters. And so typically this is what is performed in pharmacokinetics modeling. You have here some example of some concentration data, and you pool all the data together, and then you well, you estimate the population parameters. So you, instead of estimating one parameter for each patient, which leads to n times the number of parameter estimates, and which leads to often to identifiability issues. Here, you only have to estimate like if you want the mean of the Gaussian and the standard deviation of the random effect. So it's much more, it makes the estimation much more robust, and gives you a description of the population level. So this likelihood maximization, and then when you write these models and you also apply likelihood maximization to estimate the parameters, then it leads to more complex problems, and there are some well-defined now algorithms that take care of this for you, that are implemented in several softwares. Okay, so now moving on to some studies. So the first study was to so we had access in collaboration with the lab of John Ebos in the Roswell Park Cancer Institute to experimental data where they implant orthotopically tumors in mice, and then the primary tumors grow, and then they are able to observe the metastatic development, because these cells are tagged with some bioluminescent protein, so they can be observed in a non-invasive way and monitored in time. So this leads to longitudinal measurements of the primary tumor size and the total metastatic burden, such as you have an example of a group here on the right, and you can already see that this is characterized by some quite large inter-individual variability between the mice in the development of the total metastatic burden. So the questions that we wanted to address were, okay, so can we define a minimal model of metastatic development that would be both able to describe the data and be identifiable from the data? And what would be the minimal dissemination law? Can we test if there is a difference between the primary and the MET's growth law? Can we quantify the intersubject variability? And what is the impact of the primary tumor size at surgery on metastatic development and survival? So once calibrated, can we, if we remove the primary tumor earlier, what is the quantitative impact on survival? So these are the results that we obtained. So we assume the Gompertz growth of the primary, Gompertz growth of the MET, but possibly different parameters for primary and secondary tumors. The dissemination rate, I already talked about it. It's what I said. And this is the result of that we obtained on the fit of the data for one group. Here, where surgery was performed at 34 days. So again, population level fit. So where we describe. So this is the median of the simulations when we simulate the statistical distribution of the parameters estimated from the population parameters. And the 10th and 90th percentiles. So you can see that we are able to describe not only the individual kinetics that are reproduced here, but also the intersubject variability. So the main difficulty here was that in order to perform these fits, we need to run like the model millions of times, and so this was solved by and so it's not doable to simulate a full PDE model, but thanks to the nice expression of the total metastatic burden in terms of a convolution equation, then we can use the fast Fourier transform algorithm to compute the metastatic burden, which is exactly the data that is observed here. So it simplifies the estimation. The results that we obtained were that, okay, so Gompertz for breast, so this is breast experimental data, but we also had like another experimental system for kidney cancer, and there we observed that growth was more exponential and was able to be described by exponential growth law. The best model between like, in terms of likelihood ratios and likelihood of the data was gamma equal 1. the model with the same growth for primary tumor and mets was already able to describe the data. We had good practical identifiability. This is a very important step in terms of estimating the parameters with all relative standard errors smaller than 30%. And parameter mu was found critical for inter-animal variability with a large coefficient of variation of 176%. So here you can see once the model is fitted, and it's fitted on one group, and then we use the fit on one group to try to predict the outcome on a different group with different surgery performed in different animals, and you see that the prediction is quite okay with the data. So from this, we could use then the calibrated model to try to explore the quantitative link between the primary tumor size and the probability of relapse. And what we observed was that actually when so this is well, I've not detailed this part. You can find the details in the papers because this is of course for patient calibration for the human case where survival is more relevant. And what we found was a non-linear link. So basically, below a resection size, there is a negligible, below a recurrence threshold, there is negligible recurrence risk. There is a small area here where the benefit is decreases strongly, and then above some other threshold, then basically it's too late. And I mean, in the absence, of course, of adjuvant treatment, then there is only moderate improvement of the survival by removing the primary tumor because the mets are already well developed. And we can simulate survival curves according to two different recurrence risk with these thresholds. Okay, so then actually the main reason where we were approached by John and his lab was that he had some very interesting observations about the fact that when they performed experiments on mice, and they tested like an anti-angiogenic drug which is called sunitinib, and they injected the drug to the mice after the resection of the primary tumor here on the left and what they observed was that actually the groups who received the drug had actually accelerated metastasis. So that's the blue curve here. So here is the control group. Usually we see the treated growth curve, the smaller than the control group, but here actually they observed that there was an accelerated metastasis, and they confirmed this in a second paper using neoadjuvant treatment, which is more relevant in the case of kidney, and they also observed this. So we wanted to test a possible hypothesis for the differential effects of sunitinib on primary tumor and metastasis, and try to build a minimal KPD model for describing this treatment. And also they had collected several biomarkers at the time of surgery, and we wanted to try to assess the predictive power of these biomarkers on the model parameters, if we were able to predict the mathematical model parameters using these biomarkers collected at surgery. So for instance, circulating tumor cells or Ki67 or other markers, and trying to do so using machine learning algorithm. I will not present these results today. So what we performed was, okay, so now we had our model, and we had our model that was calibrated from control groups. So we had already something that was able to simulate what is the typical growth on a typical group without treatment. So the first thing we said was that to say, okay, we will compare two scenarios. One scenario, we will just stop the growth during the treatment, both on the primary and on the mets. So just we will set growth equal to 0 and see what will happen. And that's what's the result of the simulation of the prediction compared to the data. And what you see is that actually the growth RS on the mets is definitely not able to fit with the data here. And the second scenario was, okay, we just stop the growth of the primary. So the primary, so it does have a slight impact on the mets because the fact of the primary grows slower, so it will disseminate less. But no impact on no growth arrest on the mets. And actually, this was already in accordance, quite in accordance with the experimental data. Okay. So then we said, okay, so now we want to model this growth arrest a little bit more in details in order to have dependency on the drug scheduling and on especially on the dose of the drug and on the schedule. So because in the data there were multiple groups with different duration of the treatment and different breaks following the neoadjuvant treatment. In total, there are like 400 mice in this data. So it's a very large data set, very rich data set with tons of different treatment groups, and we wanted to go further to have something that was able to include the treatment schedule. So, but then we modeled only the effect on the primary tumor because this was already able to describe both data, primary and mets. And for the C of T, so this is we used the classical pharmacokinetics model for the drug that was retrieved from the literature. So this the volume of distribution and the half-life of the drug was fixed from the literature. The in vitro proliferation rate was also fixed from experimental data, and the other parameters were estimated from the fit to the data. And you can see that again the relative standard errors is really are really small, so suggesting really good identifiability of the model. Okay. Okay, maybe how long do I have left? Maybe I will, well, okay, I will try to go faster. So this was for just growth of the total metastatic burden. But now we had a collaboration with a biologist in Bordeaux where they were making some experiments where they were recording not only the total metastatic burden, but also there were images, MRI images of the size of individual tumors. And so the question was, okay, with our model, with just basic dissemination, basic growth, can we describe data of both number and size of the mets? So what we did was, okay, we also have like the metastatic burden data. We do the same. So we fit the metastatic burden data using the model. Again, good identifiability, it's okay. So, and then we perform predictive simulations of what this fit of the macroscopic quantity gives in terms of size distribution. And this is the comparison of the size distribution between the theory, the model that we had, and the data. And again, the macro burden is the same. The macro burden, even if it's recorded here from MRI, you can see that the difference between the data and the model is quite small, and that the model is in accordance with the data in terms of the total mass, total size of the tumors. But what you see, that is very interesting here, is that the size distribution is actually completely different between the tumors, between the theory and the data. What you have is that in the data you have much larger mets and much less tumors. So you have less. Or in other words, you have more but smaller metastases in the theory than in the data. So then this led to the generation of some hypotheses of what could lead to this. So maybe there are some non-trivial interactions between the tumors, and maybe two independent tumors that had been born independently, then later they merge and they give rise to one tumor. And actually, looking back at the data, we observed this. Like, we had not observed this looking at the data at first, but we observed two tumors that you can see here in the lungs of these mice. We observed that actually these two tumors were forming only one tumor at day 24. So this actually occurs in, or at least in this experimental system. And the other we were very fond of this. We at least from a theoretical point of view, it's very attractive. The other possible hypothesis was that there are interactions between the metastatic tumor and the circulating tumor cells. So maybe the fact that tumors are bigger is because new cells that arrive in the lungs, for instance, then they don't create a new met, but instead of creating a new met independent lesion, which is hard because you have to invade, like to establish foreign tissue, then maybe they already join established tumors. So in order to test this hypothesis, we asked our biological colleagues if they could do the following experiments where they were implanting one tumor that was colored red, and then they were also injecting metastasis cells in the tail vein so that they would go to the lungs and form metastasis, but that would be green. Or maybe it's reverse. Maybe the primary tumor is red and is green, and the mets are red. And then, well, the question was, do we observe in the lungs then mets that are either only green or only red? This would invalidate the second hypothesis. But what we observed actually was that there were some tumors in the lungs that were both red and green. So this suggests that cells are able to migrate and to move towards established tumors. So this is linked to different theoretical hypotheses around the biological mechanisms behind metastasis, and this is quite interesting. So I will skip this part where we also built a spatial model that was able to start from the size of the primary and the size and shape of one met, and to grow and to reproduce more or less the experimental data on the spatial side. Okay. Okay. So
you have more or less 10 minutes left.
Yes, that's what I was looking at. So unfortunately, I will have to skip, I think, this part. So I will just tell it in two minutes. Yeah, the main observation here is that the question was now to look at interactions between existing tumors in the same organism. So at this again, thinking at this organism scale, and possible inhibition of one tumor on another. And so what I did during my postdoc in a biological lab, what I did was to implant two tumors in the same mice, and then to look at the growth and to see if the growth was similar between the two tumors, or if there were differences between these two tumors. And this is some results of these experiments where you have like the two tumors in the same animals, and you can see that there is always one tumor that is large and one tumor that is small. There is always one tumor somehow winning on the other, or one tumor at least inhibiting the other. And what I did was to test three possible or several possible biological hypotheses by translating these biological hypotheses into mathematical models for reproducing this phenomenon. And the main result is that several biological models were not able to describe the data, whereas the proliferation inhibition model was the best one when we were looking at the likelihood of the model. So now I'll try to go on the clinical aspects, and one question was to try to describe brain metastasis that occur from a primary tumor that is in the lung. And this is a very important question for clinical oncologists and radiotherapists, because they have to decide whether, when they observe, for instance, one brain metastasis that occurs, and they have to decide whether they perform only a local intervention, so just a surgery or just a stereotype or a very focused radiotherapy, or if they have to perform a pan-cerebral irradiation, which has a very high toxicity and leads to very important cognitive impairments of the patients. And so this is still an open question to decide and to have criteria to decide between these two therapeutic options. And so our ambition in this project is to, from data at the first relapse, so this T2 here, where there is the primary here and there is some first met, try to estimate to estimate the parameters of the model and to predict what are the invisible mets. And so the first thing that we did was to see if the model was able to. So we had one patient here that had the growth of several brain mets that were occurring, and we had images of the mets, so we could count the number and the size of the mets, and we looked at the ability of the model again to describe this size distribution evolution in time. So you can look at this paper to have more detail, but basically again, the main difficulty here was that we had to, like here, we had to fit the full PDE, because we wanted to have the full size distribution. And we tested different theories using dormancy or not. And what was found was that the model with dormancy was necessary to describe the data. We could quantitatively estimate the duration of dormancy and you see a comparison here between the model and the data on the fit. Okay, and the last project, the last thing. So these are results that have been published last year or 2 years ago, but this is still an ongoing project. It's in in early stage breast cancer. And in early stage breast cancer, again, what you want to do is to be able to personalize the adjuvant therapy. So to say for a given patient, now they all receive 6 cycles of chemotherapy. I mean, of course, there are some adaptations, but basically in some subgroups, it's this. And the question is, can we adapt this and can we reduce the number of cycles for patients who have a low risk of metastatic relapse? And for this, we have access of, we have worked on a database from the Bergoni Institute, where they have 642 patients that did not receive adjuvant therapy. And so this was important to try to assess first the ability of the model to describe the data with no treatment. And they have 21 features at the time of diagnosis. So you have menopausal status, you have hormonal receptor status, Ki67, and some other more exotic biological markers. And so we have, and in this database, we have the outcome, which is metastatic relapse, yes or no, and the date of metastatic relapse. And what we did was to extend the framework of the model to try to describe this survival data. And we did so by using this TTR and comparing and using a mixed effects model for distribution of the TTR. So in other words, we are fitting the survival curve, and we have to take into account the fact one very important point in this data is that these are censored data, right censored data. So we have to take this into account in the derivation of the likelihood. And also the difficulty is to try to have a good selection of the covariates, because when the models, they are predicted by the model parameters, mu and alpha, they are predicted by the covariates, the individual covariates xi, and we cannot test in the full mechanistic model all the possible covariate models because it's too long. So we first used a selection of the covariates using a random survival forest algorithm. And that selected five covariates. And then these covariates, we use them in the model. And we could find two, so there are two very interesting results from this work, is that first, the model was able to not only describe the data, but also to predict. So this is an example of a simulation of a predicted simulation of the natural history of a patient between, and there is the prediction of the time to relapse and the actual observed time to relapse. And you see that, that the model the prediction is quite accurate. And this is quantified by the calibration curves here at the population level. We actually did as good as other classical statistical models, such as Cox regression for prediction of survival, or machine learning models. But also, the interesting thing here is that we can learn on the biology, because we can learn what parameters, what covariate had an impact on what biology, what mathematical parameter. And here, for instance, we found that Ki67, which is a very well-known proliferation marker, was significant in alpha, but not significant in mu. And this makes sense because it's a proliferation marker, so it has to impact growth. But it was reassuring, and we also found that these other markers, they had distinctive effect on alpha and on mu, and this leads to a new biological insight. Okay, so in summary, what I've shown is a quantitative mathematical framework for modeling metastasis that is very simplification of the process, and it helps to test biological hypotheses, and also it can be translated into predictive tools for clinical applications. And we are moving forward currently towards prediction tools of direct help at bedside by using only routine markers, and also by integrating, of course, the treatment in the model that is not included now. Okay, so with this, I would like to thank you all for your attention, and thank all the collaborators that have been involved in all this project.
Thank you. So, okay.
Thank you for the great talk. This was very interesting work. I was wondering if the experimental data you considered for the first part of this talk, whether the primary tumor was always in the same site, or whether you consider different locations for the primary, and if that had any impact on the total metastatic burden or the size distribution.
Yeah, thanks for the question. That's an interesting question. We did not. So here, the point of these models, so-called clinically relevant orthosurgical models, was really to try to mimic as much as possible the clinical situation. So there were only orthotopic implantation. That means at the site that so in the mammary fat pad, which is the equivalent of the breast in mice. So for the breast tumors, they were injected like this. For the kidney tumors, they were injected in the subcapsular area of the kidneys. So no, it was always at the same site. There are also some data with injections on on the back, which is typically where you implant the tumors when you don't want to go into very complex situations. But I don't have data on quantifications, so I can't. Yeah.
Thank you. Is there any other questions in the room? So you have a question, or? Okay, me too. So I will ask first. So just in your models, maybe you said it and I miss it. Is it very sensitive to the initial condition? Because I assume that is an information that is really difficult to know. And did you explore that, or are you assuming like it's zero and it grows from nowhere, or?
Okay, so the initial condition typically of the model is primary tumor equal 1 cell, metastasis equals 0. This can be, this 1 cell can be discussed. I mean, we can, but basically it's whether it's 1, 10 cells, 100 or 1000, it's not very sensitive to this.
Okay, thank you.
Thank you for the interesting talk. My question ties up somehow to the first question. I thought if you consider the idea of making the dissemination rate site-specific. So at the moment you have that the dissemination rate depends on the volume or the size of the tumor, but does not depend on the position where the tumor is, right? So you could imagine to take your parameter, I think it was called mu, or I mean another parameter that you could include in that equation, site-specific. Would that make sense?
Yes, that's a good point. But typically, we are making the model cancer type specific. So when we are making we are making the model for the breast, and then for breast cancer, and then we assume that the tumors in the breast, they all have like the same shape of the growth curve. But we did observe, for instance, this gamma, you know, like we did observe that the gamma equal 1 was able to describe the data for breast tumors, but for the lung, you know, the clinical lung case with the brain mets, it was not gamma equal to 1. Gamma equal to 1 was not able to describe the data. So we should go back to the paper, but I think it was gamma equal something smaller than 1 and something that was not 0, but maybe 2/3 or.
Okay, so somehow you already captured the specificity of the site by choosing the proper value of gamma, in a sense.
Yeah, that would be,
Okay.
But of course, that would be also relevant to your question for if we include secondary sites, secondary tumors, and then we include the possibility of secondary tumors to disseminate. And then, of course, one thing that would be needed if we are at the site level is to distinguish between dissemination power from tumors that would be in the lung, from metastatic tumors, I mean, that would be in the lung, and metastatic tumors that would be in the liver, or metastatic tumors that would be in the brain, where it's much harder to eliminate. And so.
Okay, thank you very much.
Okay, so we can thank all the speakers again for this morning.